Good morning, everyone. Good evening, everyone. So we'll repeat this class again. As last time we could not able to complete it properly. So it is about leukocytes. So, being a NEET PG students, sorry. Okay, being a NEET PG student, you might have heard about the blood and all those things, blood physiology. Same thing we are going to talk here regarding blood physiology. Okay, so in blood physiology, previously we talked about plasma proteins. Then we completed the RBC. Now we'll start with the WBC. So what you know about the WBC? They are named white blood cell because they are colorless, as RBC is named red blood cell because of their color. Similarly, they are named as a white blood cell because they are colorless. Another name of WBC is leukocytes, and leuko stands for whiteness, white color or paleness. That's why name is given leukocytes, white cells. Okay, but actually these cells are not white, but these are colorless cells. Then, if you see the WBC in RBC, there is only one are erythrocytes, and there is only one type of the erythrocytes. But the WBCs, there are many different varieties of the WBCs are found in blood, and depending upon the different types and their morphological features, the WBCs are classified into two major groups. One, WBC which contain granules. So presence of granules in WBCs, they are called as granulocytes. And second, WBCs which doesn't contain granules. Those WBCs are called agranulocytes. So WBC which has a granules are granulocytes, and WBC which doesn't have granules in their cytoplasm are called agranulocytes. So sometimes there is a more confusing term that is called as a agranulocytosis. So many times you get confused. Agranulocytosis means it is not the absence of granulocytes, but it is increased number of um, agranulocytes. Cytosis word is usually used for increased number in the cells in the blood. While if we want to refer to anything which is a absence, then it will be the penia. Okay. Then come to the in granulocytes. If you depend upon the type of the granules which present in the granulocytes, they again divided into different types. So granules, whenever we classify these WBCs and whenever we identify WBCs, we usually use Leishman stains. Leishman stains which contain a eosinophil, which is a more of like a acidic dye which stains the basic material present in the cells, while it contains methylene blue, which is more of basic dye which stains the acidic material which is present in the cell. So when we stain this blood smear with Leishman stains, and then we see under microscope, the neutrophil is the cell which contain the granules, which takes stains from the both acidic dye and basic dye. That is stained with the eosinophil also and methylene blue also. So it shows the granule which is somewhere around from the pink to purple color, and that's why it is also called as a neutrophil. Neutro means neutral to the both acid and base. That's why name is given neutrophils. And phils means liking. So neutrophil are the having the granules which like both acidic stain and basic stain. The second type of the cell is eosinophil. Eosinophil is a cell which contain the granules which like the eosinic stain, that is acidic stain. So it contain basically granules contain basically basic materials, and because of that basic material, it attracts more acidic stain, that is eosinophils, and that's why the name is given eosinophil. So eosinophil are the cells which contain the granules which loves eosin. Okay. The last type of the cell in the granulocytes is basophil. So as name suggests, Here the granules has a more acidic content and they like the uh, basic dye, and that's why name is given basophil. So they had a granules which is stained with a blue color, while eosinophils are stained with the red or orange color. Then come to the agranulocytes. Agranulocytes are the cells which doesn't contain the granules. In this, there are two types of the cells are identified. One is lymphocytes. These are a major part of the acquired immune system, and it contains two types of the lymphocytes: T lymphocytes and B lymphocytes. But morphologically, if we see, there are two types of the cells which can identify on the peripheral smear. There are small lymphocytes and large lymphocytes. So functionally, they are not different. Only age. Small lymphocytes are more matured, while large lymphocytes are immature. Then come to the monocytes. Monocytes is one of the largest cells which present in the cell, and it contain one big nucleus and along with the abundant of the cytoplasm. आदित्यवास टेलीग्राम ग्रुप है IHSM फिजियोलॉजी. Okay. Then come to the count of the WBC. There is always variation in the count, and it is not a fix. But after various study, we fixes the range. So we consider 4,000 to 11,000 of WBCs per cubic ml of the blood or microliter of the blood is considered to be normal. So any count which is more than 11,000 will be considered as a increase in leukocyte count, and that condition we call it leukocytosis. And any condition where decrease WBC count below 4,000, we call it as a decrease in leukocyte count, and that is named as a leukopenia. So 11 to 4,000 is your normal count. But if you see, this leukocyte count is not constant and it varies with the age. So immediately after birth, the fetus is a lot of under stress, so their leukocyte count is very, very high. So immediately after birth, if you see leukocyte count is somewhere around 20 to 25,000. So 10 to 25,000 we consider normal for the baby, and as the age increases, the count will start decreasing, and it comes somewhere around 6 to 16,000. And as the age progresses, the count will, by the age of the 10 to 12 years, it will start becoming up to the adult age. Okay, and similarly at the older age, I told you, no, let me finish topic, then you can ask these questions. Yes, all topics which I am teaching you are always present in Indocrana. Indocrana is good book. It covered complete physiology almost. There are hardly few topics which he is not touched, but maximum topic is covered in Indocrana. Okay. Then come to when we're doing the total leukocyte count. This method is called a TLC, total leukocyte counting, and it is done by with the help of Neubauer's chamber. It method is similar like that of the method of measuring RBC counts. So here we'll take a blood puncture or ring finger, and we'll take a drop of the blood into the pipette, and we dilute that pipette 10 times with the diluting fluids. And the diluting fluid is called Turk's fluid, which contain methylene blue and acetone. And this methylene blue will stain the nucleus of the RBC, and that you can easily see under low power microscope, where you can see the blue dots as a WBC, and that number of WBCs you count it on a Neubauer's chamber. Okay, but there are another, as I said, there are variety of the WBCs there. So many diseases, the one WBC increase, another WBC decrease. So total leukocyte count may not be so diagnostic for us. So we want differential leukocyte counts. So individual type of the WBC count we want, and that we do it by the peripheral smear. जो आरबीसी का भी हमने बात की थी कि पेरिफेरल स्मीयर में we can see the morphology of the RBC. Similarly, with same peripheral smear, by doing Leishman stain, we can see the morphological features of various WBC, and by knowing the morphological features of various WBC, we count individual percentage of the WBCs, and that gives, like if you see for neutrophils, normal ranges from 40 to 75. Eosinophils is from 1 to 6, and basophils from 0 to 1. At the same time, Second highest concentration is about the lymphocyte, that is 20 to 40%, and while monocyte has currently 2 to 4%. Then this percentage what you got in a WBC count. Please don't disturb for the silly questions on this. If you want Telegram link, you can ask me after class also. Everyone has my WhatsApp number. अभी जो लाइव चल रहा है उस पर बात कर लो, बाद में रिकॉर्डेड देख लेना. Or should I stop class and I will keep on sending individual Telegram link? चैट बॉक्स देख लो, चैट बॉक्स में भी टेलीग्राम लिंक डाली हुई है मैंने. So when you get an absolute count, then when you get that percentage count on a peripheral smear, then you'll multiply this percentage with your total leukocyte count, and then you'll get an absolute WBC count. And this is how the differential count and absolute count will be done in the individual. Nowadays we have a cell analyzer, so we'll directly put into cell analyzer and you'll get a direct report. But that cell analyzer has to be calibrated regularly by doing manual counting. Then come to the variations in the WBCs. There can be increase in the count or decrease in the count. Whenever there is increase in count, that condition is called a leukocytosis. And whenever count goes below 12,000, we consider it as a leukocytosis. Causes of leukocytosis can be both physiological and pathological. Physiological means when there is no disease, normal routine daily activities में कभी-कभी count बढ़ जाता. Those causes we consider as a physiological causes. And pathological when there is actual disease is present. So when there is pathology present, then we consider it as a pathological causes. So come to the physiological causes. It is first is age criteria, which I already said. It is very high leukocyte count in immediately after birth. It is slowly increase, and it is always little bit higher in kids, from infants to some newborn to infants to up to 5 years age. It is always little bit higher than adult because they always under increased activity in their normal stress, injuries, and all those things keep on happening to the children. So their count little bit higher, but as the age increases, it comes to normal, and as it become older age, then your count will start slowly decreasing. Then come to the exercise. Immediately after exercise, there is a increased count of the WBC. It is because of increased sympathetic activity that will causes a vasoconstriction. That vasoconstriction will pull the marginal pool of the WBCs, put it into the central pool. That will increase your WBC count. Then immediately after food intake, similarly, if on food intake there will be vasodilatation of the GI tract, more requirement of blood, and when there is more requirement of blood, it will cause vasoconstriction in the blood vessels which are present in the skins and muscles, and the blood will divert it towards the GI tract. And during this process, also marginal pool of the WBC will come to the central pool, and that will increase. Mental stress, again mental stress will increase sympathetic activity, that will cause a vasoconstriction, that will increase. Then exposure to the low temperature, which again causes vasoconstriction, and that will also increase your WBC count. Now come to pregnancy. Pregnancy is a physiological process where a woman conceives and rear the fetus in her womb, and this is one of the bigger stress to the mother, and that stress will causes more release of the WBC into the blood, and because of that there is increased WBC count in pregnancy. Then come to the pathological causes. Pathological causes, whenever there is any stress or any threat comes to the body, then there is an increased WBC count. Example like acute bacterial infection or pyogenic infection also, and non-pyogenic infection also many times increase WBC count. Then damage to the tissue like burn, myocardial infarction, road traffic accident, in that post-operative cases, there is increased WBC count. Then acute hemorrhage will cause a severe vasoconstriction, that will also increase WBC count temporarily. And then chronic infections like tuberculosis and glandular fever, they are also increasing WBC count. Then come to the decrease in WBC count. That condition is called leukopenia, and whenever you get a count lower than 4,000, we consider it as a leukopenic state. And here there is no physiological causes but decrease in WBC count in normal routine life. So normal routine life में कभी physiologic cause physiologically WBC count कम होता नहीं. So there is always pathological causes for the leukopenia, and those causes are presence of non-pathogenic infection. Example, enteric fever, that is typhoid fever and paratyphoid fever together is considered as a enteric fever because they infect the GI tract. GI tract is also called as a enteric system. So because of it, they infect the enteric system. That's why they are also called as a enteric fever. Then viral infections like smallpox, chikungunya, dengue, influenza, mumps. These viral infections also decrease WBC count. Then protozoal infections like malaria and chalaza also, there is also increase in WBC count. Then come to the bone marrow. Whenever there is decreased activity within the bone marrow, it will not only decrease the WBC count but also decrease the counts of other cells like RBC and platelets also. Then whenever bone marrow is depressed because of many other reasons like chronic exposure to the radiations, then treatment with the cytotoxic drug or anti-cancer drugs, or whenever there is a exposure to the metals like arsenic or diphenol or antimony. During this condition also there is a decrease in WBC count. Another one condition where WBC count usually first increase and then start decreasing is a treatment with the steroid therapy. So when you will give steroid, initially there is a little bit increase in the WBC count, but they will slowly start decreasing the WBC count when you are treated them with the long-term steroid therapy. Then come to the formations of the WBC, that is called leukopoiesis. जैसे erythrocytes का formation होता है, we call it erythropoiesis. Similarly, when there is a formation of WBC, that time we call it as a leukopoiesis, and it forms the part of hematopoiesis along with the erythropoiesis, leukopoiesis, and thrombopoiesis together will form hematopoiesis. So here WBC are generated from the pluripotent hematogenic cells. So this pluripotent hematogenic cell is a large cell and which can differentiate it into any part. Like it can be differentiated to RBC, or it can be differentiated to WBC, or it can be differentiated into megakaryocyte, that is thrombocytes. So which are the common origin for the all three formation of the WBC, that is called pluripotent hematogenic or hematopoietic stem cells. These pluripotent hematopoietic stem cells will expose to the particular chemicals, and those chemicals will lead their differentiation into whether it's going to be erythrocyte, WBC, or macrophage. So for converting the pluripotent cells into the leukopoietic cells, it has to be exposed with the particular factors, like those factors are called colony forming units. So if the pluripotent cell or stem cells will expose to the colony forming unit, which will forms neutrophil lineage. That factor is called colony forming unit G. G stands for granulocytes. Okay. Previously they thought it forms all three types of the cells, but it forms only neutrophil. So it is called neutrophil colony forming unit. Then another is eosinophil. When they expose to the that particular unit, then it forms eosinophilic cells. So these are like a different colony-forming unit will be there. Another thing, they also has a different series from the granulocytes. So granulomonocytes has a different lineage and lymphocytes has a different lineage. So it is either from the cell when pluripotent cell forms into lymphoid formation or lymphocytes formation, then with that lineage is called lymphoid lineage of the or lymphoid lineage or lymphoid series. Well, those will form the granulocytes or monocytes is also called as a myeloid series or myelomonocytic series. Okay, so these together will form different series depending upon the what type of the factors they are exposed. So if you see how this leukopoiesis occur, and if you consider only about the granulocytes, then stem cell will expose to the particular colony forming units, and once this get exposes, it will first convert differentiated into uh, what we call specialized stem cells. A pluripotent generalized होगा सबके लिए, so it will become more specialized stem cell, and now it will become pluripotent myeloid stem cells. Once it will become pluripotent myeloid stems, from there it becomes properly differentiated precursor cell of the myelocytes, and that is called myeloblast. Once the myeloblast will be there, the myeloblast will again mature and will become pro-myelocytes, and then it will become myelocytes. Once it become myelocytes, depend upon what type of the colony forming stimulating factors and colony forming unit factors has been exposed, it can be either converted into neutrophil, or it can be converted to eosinophil, or it can be converted into basophil. So cell which converted into eosinophil is called eosinophilic myelocytes. One converted into neutrophil is called neutrophilic myelocytes, and which we convert to basophil will be called as a basophilic myelocytes. And then within the bone marrow, they'll become matured into eosinophil, basophil, and neutrophils, and then they will release into the blood as a matured WBC. Another is a development of the monocytes. Similarly, hematopoietic stem cells will be there, which converted into myeloid stem cells, and then myeloid stem cells is converted into myelomonoblast. This is a precursor of the monocytes. Once the myelomonoblast will form, then from there it will form promonocytes, and from promonocytes it will form matured monocytes. So promonocytes will usually in the bone marrow. Once it gets matured, it will come into the blood, and, this monocyte has another fate. If these monocytes will remain into the blood, they will die after few hours. Okay, but if they move to the tissue by stimulation or inactivity, they will convert it into macrocytes. They become more larger. That is called macrophage. And in the tissue, these macrophages can stay alive for days to years. Okay, so monocyte has a two portion. One is which in the blood, that is called monocytes, and one which is in the tissue, that is called macrophage. That's why many times this monocyte system or monocyte cell is not considered as only cell, it is considered as a system, and they refer to it as a monocyte macrophage system. Previously, it is also called as a reticuloendothelial system. Then come to the lymphoid formation. So lymphoid formation will start with the stem cells, will convert into lymphoid stem cells, and lymphoid stem cell will convert into lymphoblast cell, which is one of the large cell and having a more acidic coloring cytoplasm, and very big nuclear, which has a stippled or crumpled chromatids. And nuclear membrane is also not that much dense. Then it will becoming smaller as it progresses, and it will become first pro-lymphocytes, and then it will become lymphocyte, which is a more matured cell will be there, that will have very strong pale blue color of the cytoplasm, and nucleus will become much dark blue color nucleus, and also quantity of the cytoplasm will decrease very less, and it will only form the rim of the cytoplasm surrounding the nucleus. So this is a typical feature, identification feature of the lymphocytes, where nucleus is very large and very scanty cytoplasm. So if you consider volume part, so nucleus will have a larger portion of the volume, or occupies much more volume in the cell as compared to cytoplasm. That is a biggest identification of the uh, lymphocytes. Then come to the regulation of the lymphocytes. So before going for the regulation, I just want to ask you, what are the site where this leukopoiesis occurs? हमने पूरा बात कर लिया, but we didn't able to ask what are the sites. So you can message me in the chat box. So what are the site where you can see leukocytes? Synthesis leukopoiesis कहाँ कहाँ होती है body में? Okay, bone marrow. Apart from bone marrow, okay, fine. ये लिम्फोइड ऑर्गन में नहीं होती, थाइमस में भी नहीं होती, सॉरी। ओके, फाइन फाइन। ओके आयुष, थोड़ा स्लो हो जाएंगे आप। Yolk sac started. So when it comes to site of where actually leukopoiesis occur, it is are the same site where erythropoiesis also occur. So immediately after fertilization, yolk sac will be formed, and the first where the leukocytes or erythrocytes or thrombocytes will form is formed in the yolk sac. As the age progresses, in the third or fourth month of the gestation, liver and spleen will start developing, and now liver and spleen will start doing erythropoiesis and leukopoiesis. Okay, and as the age increases and bone will start developing, in the bone marrow will be there, and almost all bones in the body will contain bone marrow, and bone marrow will start developing RBCs, WBCs, and platelets. And so during interternal life, we'll get a RBC, WBC from liver and spleen also, and from bone marrow also. But as the age increases in interternal life, from fourth month to ninth month, the amount of the RBC which is synthesized, or WBC which is synthesized by the bone marrow, will keep on increasing. So it will take over the charge from the liver and spleen by the bone marrow. So bone marrow will take over the charges from the liver and spleen as the age progresses, and at the time of the delivery, there hardly any leukopoiesis is going on in liver and spleen, while complete leukopoiesis is going in bone marrow. So at the time of the birth, it is the bone marrow is the major site where the leukopoiesis occur. But as the age increases, the quantity of or site of the bone marrow is also start decreasing. So bone marrow which present normally and shows the erythropoiesis and leukopoiesis are usually called red bone marrow, because there is a lot of red cells you will see. And if you take a puncture, then that bone marrow will look like a more red. But slowly as it increases, this bone marrow will start replacing with the fatty tissues. So it will completely replace the cells, and it will be deposited with the fatty tissue. And now it will look more pale or yellow color, and that's why they are called yellow bone marrow. So once you reach to the adulthood, it is only the mm, flat bones like sternum, ribs, uh, iliac crest, or some part of the cranium, where you will get red bone marrow, where the erythropoiesis will be continuously occurring. While sometimes in a long bone like a tibia or femur at the end there, you will see the little bit red bone marrow, while all other bones marrow will completely replaced by the yellow bone marrow. Bone marrow forms both B lymphocytes and T lymphocytes. Okay, so now come to the regulation of the leukopoiesis. As I said, leukopoiesis is regulated, uh, or there are factors which decide whether it has to be lymphocytes or monocytes. Similarly, कितना बढ़ना है क्या बढ़ना है. So to factor which stimulate the leukopoiesis, these are called colony stimulating factors. So colony forming unit which differentiate the hemopoiesis or stem cells into different types of cells. The colony stimulating factors are factors which stimulates the formation of these stem cells, and these are called G, which granulocytes which stimulate the granulocytes formation. G, CSF. MCSF will stimulate the monocyte formation, and GM will stimulate both granulocytes and monocyte formation. While there are the cells which release by the chemicals which released by the lymphocytes are called interleukins or cytokines, and these cytokines also stimulate directly formation of lymphocytes and also with the other precursors. and also prostaglandin is also stimulate the formation of various precursor, more specifically about the monocytes. So these are the few factors which increases the formation of the leukopoiesis. And when these factors will release, basically these factors release when there is an increased tissue destruction or when there is increase in inflammation in the body. During these factors, and these factors specifically released by the their own cells of the lymphocyte. WBCs only release these factors when they become active. Okay. Another thing apart from this, factors which release during tissue destruction will also stimulate the leukopoiesis, like tissue necrotic factors and growth factors. All these factors will release into the blood and they will also stimulate the formation of leukopoiesis. So the sixth participant has been raised hand. Can you message me why you raise hand so that I can act accordingly? Yes, please. Mohammad Shaban, Samarth Subhash, Mohammad Zubair, Dinesh, Viraj, Minaz. You can, okay. Should I allow you to talk? Okay, you can talk now. Please, you can speak up. Now come to the individual leukocytes. Okay, then come to the neutrophil. So whatever you are seeing this diagram is a line diagram. So it is not actual picture. It is just representative and try to understand the various features of the neutrophil. So whenever you do peripheral specimen, how will identify the neutrophil? So identification will be done on the morphological features. So first and most important point where you can see in the morphological picture is the size of the neutrophil. So size, it ranges from 10 to 14 micron. And how we measure this size? We'll always compare this size of the neutrophil with the size of the RBC. So RBC is somewhere around 7 micron. So any cell which you'll see more than half and 1.5 size of the RBC or up to the double size of the RBC, then that cell will be the neutrophil. First is the size. In second, you will see about a nucleus of the cell. Second criteria will be the nucleus of the cell. And if you see the RBC's, neutrophil's nucleus, it is a multi-lobed shape of the neutrophil. So it will vary from 2 shape to 6 lobes, 2 lobes to 6 lobes. So there is a uh, different shape of the nucleus you will see in the neutrophil. Younger the neutrophil, there will be less lobe. As the neutrophil become more and more mature, it will keep on increasing the number of the lobes. So it will reduce from 2 lobes to 6 lobes. But ideally, maximum neutrophils you will see in between 3 to 5 lobes when you are checking it on a peripheral smear. And because of the typical nature of these neutrophils having different shape of the nucleus, it is also called as a polymorphonucleocyte. Okay, so the polymorpho, poly means different or many, morpho means shape, nucleo means nucleus. So this is cell which has a many shapes of the nucleus. That's why it is also called as a polymorphonucleocyte. So sometimes you might get a question about a polymorphonucleocyte or polymorphs or neutrophils. So they are all with the same. Next criteria where you will see it identification is cytoplasm. बिग स्क्रीन ही है, क्या हो रहा है? मेरा स्क्रीन छोटा हो गया क्या? आई डोंट गेट यू. You please raise your hand. I will allow you to talk so that you can talk to me. क्या कौन सा स्क्रीन बड़ा चाहिए? पीपीटी नहीं दिख रही बड़ी क्या? ओके, हाँ बोलो विकास. विकास बोलो. So cytoplasm usually pinkish pale color. Colony stimulating factor. Full form of the CSF is colony stimulating factor. Okay. So cytoplasm is neutrophil is a pale or pinkish pale color because it contains both eosin and methylene blue stain, both acidic and basic stain. And similarly, its granules also take both acidic and basic color, and they will show dark pink to purple color of the granules. Another feature of these granules are they are very fine. Pyogenic means infection which can produce pus. Pus forming infection are called pyogenic infection. Non-pus forming infection are called non-pyogenic infection. Okay, like enteric fever or typhoid fever, when they infected and they destroys the tissue, they will not form the pus, and that's why they are called non-pyogenic. Similarly, if you go to the staphylococcal infection or staphylococcal infection, when they destroy the tissue, they will form a pus, and that's why they are called pyogenic infection. And more detail you will find it in a microbiology, how these can be differentiated. Okay. Then come to granules. Granules here are very fine. They spread evenly and abundantly in the whole cytoplasm, and they will never cover the nucleus. So nucleus will not covered by those granules. You can easily see the nucleus, identify the nucleus, and you can see the granules. They are really very fine, so one cannot discriminate between two granules. They all merge in each other. If you see the content of these granules, so granules will contain lot of enzymes which are bactericidals like a glycosidase, phosphatase, sulfatase, nuclease, proteolytic enzymes. Apart from this, they also contain a histamine and peroxidase. And these granules will act on the bacteria and try to kill the bacteria. Then come to the fate of the neutrophil. Normally, when a neutrophil releases into the blood, so only 50% will release and keep on moving in the circulation, while remaining 50% will stick to the endothelium of the capillary. So this is a blood vessels. So blood vessels are two pools. So neutrophils are also seen here also, and the few are moving here. So they're also attaching themselves to the margin or endothelium. So these are called marginal pools, and this is they also keep on moving in the center. So 50% will remain into the margins of the endothelium, and they are called marginal pool of the neutrophil, while remaining 50% will keep on moving in the blood. And these two pools are always in an exchange, or they continuously change. So whenever they decrease RBCs from the central pool, so it will come from the marginal pool. When there's increase WBC from the marginal pool, they will. Muskan, if you want, you can go. Okay? You people keep on disturbing the class, and that's why it's keep on delaying. So come to the marginal pool, and in the marginal pool, they are usually lined with the all type of the capillaries, venules, sinusoids, even small veins. They are all present there, and will stick to there and remain there. Whenever there is a increased requirement of the neutrophil will be there, then this will stimulate the sympathetic activity that will causes a vasoconstriction, and this marginal pool will move into the circulating pool, and there will increase count of the neutrophil in circulation. If you see the lifespan of this mm, RBC, so RBCs remain into the circulation for 8 to 10 hours, and then they will enter into the tissue. If they don't enter, then they will goes to the spleen, and there will they will be destroyed. So once they go to enter the tissue, they'll perform their phagocytic action, and then again they will die there. Then come to the functions of the neutrophil. Uh, it is one of the most important functions of the neutrophil is a phagocytosis. So neutrophil phagocytosis means we already discussing the transport membrane. It is like a equal to uh, cell eating. So they will start engulfing or eating the other cells, cell fragments, bacteria, or large protein or any foreign bodies. They will try to engulf, try to digest it, and even some try to kill it. So this process is called phagocytosis. And by this mechanism, they will try to remove the water threat is there to our body, that will be try to remove by the neutrophil. Then come to the inflammation. Neutrophil plays very important role in the inflammation. When they're trying to kill the bacteria or trying to kill the microorganisms, during that time they will become active, and active neutrophil will release lots of proteins into the surrounding tissue, and these are called interleukins or leukotrienes. And apart from the interleukin leukotrienes, it also releases the thromboxane and prostaglandins, and these are inflammatory mediators, and they will initiate the inflammatory reactions. So there are four cardinal signs of inflammation, that is Ruber, tuber, calor, and dollar. So all these four reactions can be seen by the chemical mediators of the neutrophil. So they increase the causes vasodilatation at the site of the inflammation, and they will increase in the blood supply, and that will give reddish color to the site of the inflammation. Apart from this, it also increases the capillary permeability, and protein will lose from the blood vessels and accumulate into the tissue fluid, and that will give swelling, that is tumor. So there will be increased swelling at the site of the inflammation. Third thing, there is increased blood supply and also increased metabolism. So there are high metabolic activities keep on going on there, and that will causes increased temperature at the site of the inflammation. Last thing and most important is the pain. They release the various substances which can directly stimulate, like example prostaglandin or factor P, and that can directly stimulate to the nerve endings, and that will increases the sensitivity of the nerve ending, and that will send the pain sensation to the central nervous system. Apart from this, neutrophils also release the various chemicals into the blood that can initiate the fever, or that can uh, increases the body temperature, and that increase in body temperature is called as a fever. So another name of the fever is a pyrexia. So factors which causes the pyrexia is also called as a pyrogens. So factors we release from the neutrophil will causes fever, and those are called endogenous pyrogens, the pyrogens from our own body. Similarly, the pyrogens are also released by the various bacteria, bacterial toxins which work as a pyrogen, and these are called exogenous pyrogens or bacterial pyrogens. Then come to the detailed process of the phagocytosis, where we'll talk about the phagocytosis. So, how the phagocytosis occur? So, it is a neutrophil will keep on eating the bacteria. How these occur? These occur with a different steps. So, it is not like that. Neutrophil को पता चल गया और चला गया. So, it is first what will happen whenever there is a foreign organisms entering your body, or whenever there is threat entering our body. It will first identify the petrolink cells. These are the tissue macrophages. Tissue macrophage goes to the site where these foreign organisms enter, and they'll first analyze the thing. And if they find it is threat to our body, they will try to kill it. If they could able to kill, then it's okay. If they could not able to kill or remove that threat from the body, they will blow the whistles like any constable or walkie-talkie police एक दूसरे communicate. Similarly, they will blow the whistles. And how they will blow whistles? By releasing the chemical mediators. प्रोसेस ऑफ इन्फ्लेमेशन बहुत डिटेल में है, पूरा एक चैप्टर लगेगा. सो आई विल जस्ट 4 कार्डिनल फीचर्स आर प्रेजेंट इन प्रोसेस ऑफ इन्फ्लेमेशन, दैट इज रूबर, कलर, डॉलर एंड ट्यूमर. रूबर means redness, color means increase in temperature, dollar means pains, and tumor means swelling. So all these 4 features you will see it because of even neutrophil chemical mediators also will show all these 4 features. Okay. So once the chemical mediator released by the macrophage, it will go and diffuse to the surrounding tissue and reach to the nearby capillaries. And from through capillaries, it goes into the blood. Once it goes to the blood, it will activate the neutrophils. Once neutrophil activated, it will start the phagocytosis. How will phagocytosis start? Once neutrophil get activated, it will stick themselves to the margin of the endothelium. So centrally आप जो activate होगा, it will activated, the activated neutrophils will stick themselves into the margin, and they will attach themselves in the margin of the capillary endothelium. Once that mechanism with the attached to the capillary endothelium, that mechanism is called margination, and this is done by the protein called selectin. So selectin will bind them endothelium with the neutrophils. Once the occurs, neutrophil will form small pseudopores like amoeba. Suppose this is a neutrophil which is attached to the margin, and they will form small pseudopore, and this small pseudopore will enter through the capillary pores, which is usually fenestration present, and they will enter through this capillary pore, and they will try to move the whole cytoplasm along with the cell membrane outside the capillary pore, and slowly they will come out of the capillary. This mechanism is called diaperesis. In this mechanism, pore जो होते हैं वो तो normally capillary में होते हैं, but it also increases the size of the pore by increasing the capillary permeability. जो chemical reactions होता है, macrophage will send those different chemicals that will also increase the capillary permeability. By these both mechanisms, the neutrophil come from the capillary into the tissue. Now, once that neutrophil reach into the tissue through the diaperesis, and they will lie themselves along the line of the capillary. And now from here, they will try to reach to the site of the infection or site of the injury. And how will they identify? That mechanism is called chemotaxis. So there is whenever injury occur, here the macrophage will release the chemicals which attract the neutrophils. So those factors are chemotactic factors, and they will release in all directions. So when neutrophil comes here, he will sense that chemotactic factor. But it will not move. Yeah, either be a chemotactic factor, either be a chemotactic factor, but it will not move in that factor. It will move from low concentration of the chemotactic factor to the higher concentration. So if you see this side will have low concentration, this side will have, and it will move in this direction, and it will go and reach to the point of the highest concentration of the chemotactic factor. And that point is where actually source of the chemotactic factor are there. And this is how they could able to find the site of the inflammation. And this whole mechanism is called chemotaxis. Then come to the phagocytosis. So once they reach at the site of the inflammation, they will try to engulf the bacteria. But bacteria are not that tasty. So phagocytosis don't like phagocytic cells or neutrophils don't like those bacteria. So what they do, other type of the chemicals will attach or they process the bacteria. Other type of chemicals like complement systems chemical, complement will attach on the surface of the bacteria, or antigen antibody will attach on the surface of the bacteria, and this mechanism is called opsonization. So the chemical bacteria substances which do this opsonization are called opsins. So these complements or antibodies are called opsins. So opsins will form coating around the bacteria, and now the neutrophil has a receptors for those opsins. So opsins will attach on neutrophil cell membrane. Receptors will attach on the opsins, and slowly it will spread their cell membrane entirely around the bacteria, and it will form completely on the opposite side. And once they end into the opposite side, and the membrane will fuse, and it will form complete phagocytic vesicle, that is also called as a phagosome, and it will come entirely into the cell. Okay, and this total stage is called engulfment stage. So pseudopod will form. It forms wrapped around the complete around the um, bacteria or microorganism, and then it will engulf completely into the cell. Once it enter into the cell, it will that structure which has a cell membrane and bacteria is called phagosomes. Now this will initiate the way activate the granules, and the granule will release their chemicals into the phagosomes, and there will decrease number of granules into the cells. This mechanism is called degranulation or stage of secretion, and these all chemical or released by these granules will directly diffuse into the phagosomes and try to kill the bacteria. So that will be the last step of killing the bacteria, or degradation of the bacteria, or degradation stage. How it kills? It kills by the two mechanisms. One is oxygen dependent mechanism, and second is oxygen independent mechanism. Oxygen dependent mechanism, the various chemicals which combine with the oxygen, and convert that oxygen into superoxides, or also called as a nascent oxygens. Like superoxides are like a O2 negative charge. So normal oxygen is O2, but it has a negative charge. So that is called O2 negative or nascent oxygen. And this nascent oxygen is very strong oxidizing agent, and they can oxidize any type of the substance which comes in their way. Apart from this, they also produce peroxides, that is H2O2. And that H2O2 is also very strongly oxidizing agent, and that will try to oxidize the various bacterial proteins or bacterial lipids and try to kill the bacteria. So these both are nascent oxygen, and H2O2 will act on a cell membrane of the bacteria, and different lipids and proteins in the bacteria try to oxidize those proteins and disturb their integrity and try to kill the cell. Apart from this, neutrophil also releases the enzyme that is called myeloperoxidase, and which will convert chloride ion or bromide ion into acids, and these acids also act on a cell and try to kill the cell. Then oxygen independent, as lysosome enzymes we already talked, it contains hydrolysis and other enzymes, and these will lyse the protein which present inside the bacteria and try to dissolve the bacterial cell membrane and try to kill the bacteria. Apart from this, these also contain a cationic proteins which also react with the different proteins and try to kill the bacteria. So that's all about the phagocytosis. If phagocyte neutrophil will not able to kill or will not able to digest complete the bacteria, neutrophil not will able to do exocytosis. So it will not remove the substance which completely incompletely digested in the neutrophil, will not able to remove from the body, and it will be remain inside the neutrophil. That's why neutrophil not able to phagocytose more than 10 to 20 bacteria, and after that it will die. Okay, so that's all about the phagocytosis. Then come to the variations in the neutrophil counts. So whenever there's increase in neutrophil count is called neutrophilia. When there's decrease in neutrophil count, we'll call it as a neutropenia. So when the absolute neutrophil count goes below 10,000, then we call it as a neutrophilia. And physiological causes are similar like that of the causes in increase in WBC count. We'll come to the pathological causes. Pathological causes is acute pathogenic infection will increase the neutrophil count. And whenever there is a other causes which is not infective, but it will increase the inflammation in the body, like gouts or acute rheumatic fever or sometimes arthritis also, various arthritis, there is increase in WBC count. Apart from that, sorry, increase in neutrophil count. Apart from that, whenever there is an increased tissue destruction also, that time also there is increased neutrophil count, like example burn, road traffic accident, post-operative cases and infection cases. Example myocardial infarction or GI infection. In that cases also there is increased neutrophil count. So decrease in neutrophil count, and there is no physiological causes in decrease in count. So here we will only discuss about the pathological causes, and that is non-pathogenic infection like a bacterial infection like typhoid, paratyphoid or enteric infection, then malarial infection, then aplasia of the bone, specifically when they are treated with the X-ray or cytotoxic drugs or other poison. Apart from the steroid therapy also start decreasing the neutrophil count. So then come to the eosinophils. Eosinophil is another part of the granulocytes. It's also similar size like that of the neutrophil, and it contain various coarse granules. So as we say, how to identify the cells? First, size. Size is similar to that of the neutrophil. Then come to the nucleus. Nucleus is also purple color, but it contains two lobes. Not like a neutrophil that have 3 to 5 lobes, but it contains two lobes. And these two lobes are usually connected with each other with the thin chromatins. So the two lobes are usually connected with the three chromatins. So these are the two lobes, and they are connected each other with the thin chromatin. And this gives a typical spectacle, like a shape of the eosinophil, and that's why also called as spectacle shape. Nucleus will be there. So it is one of the most beautiful cell which you can see in a peripheral smear. Then you come to cytoplasm. Cytoplasm is a more acidophilic and appear in a light pink color. And if you come to the granules are more coarser than the neutrophils. So you can see the typical different granules on the microscope, which you can't see with the neutrophil. The second thing is they are present evenly on the cytoplasm. So it is present also on the nucleus and also on the cytoplasm, but it is not too much crowded, so you can easily see the nucleus. If and this granules color is bright red to orange color. बोलो बबरे शरद Vrutika. Okay, sorry, it is a Vrutika Babre. You raise hand. You want to ask something? So if you raise hand and if you don't speak, then I will remove you from the meeting. Okay? So then come to the color of the granules. Granules are bright red to orange color granules because they take a strong eosinophilic stain. Then come to the content of these granules. They contain various chemicals like histamine, lysosomal enzymes, and also eosinophilic chemotactic factor of anaphylaxis. Apart from this, it also contain a dense basic proteins, and because of the dense basic protein, they attract more acidophilic stain. Then come to the functions of the eosinophil. It does have mild phagocytic activity, but eosinophils are not much motile like a neutrophil. Then they plays very important role in parasitic infection. So whenever there is any parasitic infection, specifically like a tapeworm, hookworm, or any helminthic worm, they will attach themselves to the larvicides, that parasites, and they will release the major basic proteins into that larvicides, and there they very strong poisonous or strong killing agent for the larvae, and they start killing the larvae. Once the larvae dies, then eosinophil can able to phagocytose. Not only eosinophil, but other cells like a macrophage and neutrophil also help and start doing phagocytosis, and slowly it will remove the larvae from our body. Apart from these, because of these major basic proteins, also called cationic proteins, it is one of the strong, not only bactericidal, but also act on a helminth and try to kill the helminth. So that's why eosinophils are very high concentration in parasitical infection. Then come to its role in the allergic. If you see, the eosinophil count always increase in allergic conditions like asthma and hay fever. They try to detoxifying the allergic agent like which are released by the mast cell or basophils like histamine and bradykinin, and they also inhibit the activation of the mast cell. Whatever mast cell activated, they will try to stabilize the mast cell. This is called mast cell stabilization. So they will prevent the degranulation or release of the chemicals from the mast cell. Apart from this, they also phagocytose the antigen antibody complex, which can stimulate the allergic reaction. Then they contain the chemical like called uh, aryl sulfatase B, and which inactivate the sulfur containing leukotrienes, and which usually initiates the hypersensitivity reaction in the tissues by the mast cell. So they try to destroy those leukotrienes. Then it also contains the lysophospholipase, and they usually start accumulating into the eosinophils, and they form a crystal-like structure that is called Charlotte-Leyden crystal, which is one of the diagnostic feature of the bronchial asthma. Then it also provides the mucosal immunity to the body. So you will see that there is a increased number of eosinophils in the mucosal membranes like GI tract or respiratory tract or urinary tract, and they'll provide local immunity, and that is also called as a mucosal immunity. Then whenever there is increase in count, it's called eosinophilia, that you will see usually in allergic condition like bronchial asthma, hay fever, or parasitic infection like a hookworm, roundworm, and also in various skin diseases like urticaria. Urticaria is one of the common disease you will see in India. So many patients will come with urticaria. It is like a elevation of the skin, increase itchiness, and wherever you itch, in that condition there will be the increase swelling at the side of the itch, and also redness of the skin. And this is occur all because of the allergic reaction that can be initiated by mast cell or any other allergens. Okay. Then eosinopenia, when the count goes below 500 microliter, and it is usually when there is the increased stress or when there is increased pathogenic infection, or when we treat the individual with the steroid therapy. Then come to the basophil. It also has similar size and shape that like that of the neutrophil. Mm, Nucleus like 10 to 14 micron, and when you come to the nucleus is bilobed, but sometimes it can be a trilobed, and they doesn't attach each other with the thin chromatin. So sometimes they look like S shape, Z shape, N shape, or twisted type of the nucleus can also you can see. The problem with this nucleus shape is that it covered with a coarse granules, so nucleus is not visible. So come to cytoplasm. Cytoplasm is basophilic, and that's why it appears to be bluish in color. And granules are very very coarse. So neutrophil has very fine granules, eosinophil has a coarse, and basophil has a much coarser granules. The granules are very very coarse, and they take a strong basic stain, that is methylene blue stain, and they show very dark purple to blue color stain, and they are very very crowded in over the nucleus, and it almost covered nucleus completely, and it almost fill entire cytoplasm also. If you see the content of the granule mainly contain a chemical like heparin, histamine, and serotonin. That is also called as a 5-HT, and it also contain eosinophilic chemotactic factor A, that is also present in the eosinophil. Okay, then come to the functions. This also has a mild phagocytic function, but has a major role in histamine, allergic reaction, and the release, basophil release the chemical like histamine, bradykinin, and slow reacting substances of the anaphylaxis and serotonin, and that produce reactions similar to that of the allergic conditions, and like a vasodilatation, increased itchiness, tissue will react, presence of the rash, and all those things. I don't know what is this euchromatin, heterochromatin. Allergic manifestation. Then it also try to prevent the spreading of the allergic reaction. That is a major function of the basophils. And by releasing the eosinophil chemoreactive factors, eosinophil will attract it at the site of the inflammations and try to destroy the antigen antibody complex present at the site of the reaction and try to prevent the uh, inflammatory reactions or allergic reactions. It also releases the heparin, which prevents the blood clotting, and it activates the enzyme lipoprotein lipase, and which removes the fat from the blood after a fatty meal and help us to increase the fat absorption. Then come the variations. Whenever there's increase in count, it's called basophilia. Whenever there's decrease in count, it's called basopenia. Increase in count, you will see in a viral infection, allergic condition, and also chronic myeloid leukemia. Basopenia usually it is seen when they're treated with the chemotherapy, corticosteroids, or drugs which can reduce the bone marrow or in acute pyogenic infection. So mast cell is a tissue form of the basophils. So basophil once goes to the tissue will become a mast cell, and they will work as a. They'll never come back to the skin. They will remain into the tissue and produce the allergic reaction. This mast cell has a receptors for the and IgE type of the antibodies, and they always coated with IgE type antibodies. And whenever they'll get allergens which can combine with IgE type antibodies, they will release the chemicals. Yes, Muhammad Shaban, you want to tell me something? Yeah, mast cell are also leukocytes. Okay, 5 minutes break नहीं अभी 8 बज चुके हैं. So okay, we can take 5 minutes break and then we'll continue with the monocytes and lymphocytes. Okay, bye. Welcome back. Yes, Shubham, what is serotonin, histamine, and heparin? There are three different chemicals. You had any questions regarding this? Now come to the okay. Now come to the lymphocytes. Morphological lymphocytes are a little bit smaller. So, and depending upon their size, they are divided into two parts: large lymphocytes and small lymphocytes. Small lymphocytes are more mature. They are more mature, while the large lymphocytes are more much younger. So if you see size and shapes, large lymphocytes are 20 to 16 in diameter, while small lymphocytes is 7 to 10. So they are more closer to the size of the RBC. Small lymphocytes, large lymphocytes are almost double than the size of the RBC. Then come to the nucleus. It is one of the large round nucleus, and it almost completely fill the cells. So um, it light blue color it will be stained, and chromatin which is present in nucleus are like a crumpled, and uh, it is vaguely it is present, so it is very shapeless. And because of its dark blue color stain, it is look like a ink drop present on the white paper. That's why it is also called as a ink spot appearance. Then come to cytoplasm. It is very scanty. the volume of total cytoplasm is much less than as compared to volume of the nucleus, and it is always less than the volume of the nucleus. And in large lymphocytes, it's all so this is a nucleus of the large lymphocytes, and this is a cytoplasm. So they are present. Okay, it is quite bigger at what I draw. Okay, so it is something like this type of the cytoplasm which cover the nucleus. So it little bit larger. While if you come to small lymphocytes, then it just forms a rim around the nucleus, and one side is always touch. It will touch, and it is like a crescentic shape of the cytoplasm. You will look there, which is light blue, and there is no visible granules which present in the lymphocytes. Then come to the functions of lymphocytes. Functionally, lymphocytes are divided into two parts: B lymphocytes and T lymphocytes. This is yes, Razibul.
Sir, please continue, sir.
Why you raise hand?
Sir, please continue. Actually,
B lymphocytes form the part of the humoral immunity, that is, they release the chemical and act against the microorganism or bacterial infection, while lymphocytes will attach themselves to the cells and directly kill the cells. So that's a part from the parts of cellular immunity. Well, natural killer cell is the one of the lymphocytes, which forms a part of the innate immunity. They are not like a specific for the microorganism, but they for everything, and they are like a naturally killing cells. So they had a naturally habit of killing the cells, unless and until you had some tag which said not to kill me, and that tag is presence of uh, MSC molecules. So whenever the natural killer cell will be there, any molecule which contain MSC antigens on their cell, natural cell will try to kill those cells and it will act. So they provide a good immunity for the viral infected cells and also for the tumor cells. Okay, now come to the what is meant by B lymphocytes and T lymphocytes. So whenever T lymphocytes synthesis or form, they form usually in the bone marrow, and once they form in the bone marrow, they get a training or they become matured or they will learn, and they learn at the two different sites. So B lymphocytes get matured or get a training in bone marrow, and whatever the training they get a training they expose in interturn life. This happens all everything in interturn life with the B lymphocytes. They in interturn life they will expose to the all type of the antigens which present inside our body. These are called self antigens, and they will train them to recognize our own self antigens. And cells which able to recognize our own self antigen doesn't show any activity against our own self antigens, they will pass the test and they will recruited as a B lymphocytes. While cells which will not able to identify, they will start reacting against our self antigen. They will be destroyed by the system. So actually they failed and they will remove from the system. And this is only the cells which could able to recognize our self antigen will process and goes back to the blood, and then from blood they'll lodge themselves into the lymphoid organ, and that same type of the cell will able to form in the lymphoid organs. So they proliferate there and they will remain into the lymphoid organs. Where is the lymphoid organs? Lymph nodes, spleen, and other tissues are there where the lymphoid cells will be collected. These are called lymphoid organs. Now come to the T lymphocytes. T lymphocytes once form in the bone marrow and then release into the blood, and from blood it goes to the thymus. These also occur in intermittent life. In the thymus, they will train to recognize our own self antigens. So they'll expose to the all type of the antigens which present in our body. and try to recognize it as our own self antigens. And once they will able to recognize and they will not react on our own self antigen, they will pass recruited as a T lymphocytes and they will again send back to the blood and then they lodge themselves into the lymphoid organs in our body and stay there till the emergency comes. While cell which will not able to recognize our self antigen and react on our self antigens will be destroyed by the system and removed from the body. And this is how our body will prepare a acquired immune system which will not react against our self antigen. So any disturbance occur to this system, and if cell release which cannot recognize our self antigen, then they can react against our own body tissues, and that is called autoimmunity. Okay. So this is how the T lymphocytes works. B lymphocytes once become active and when they reacted and shows their activity, they will release the chemical called antibodies, and these antibodies can act on the away from the B lymphocytes and act on a different part of the cell. They can kill the cell directly, they can immobilize the cell, they can neutralize the cell or neutralize the toxins, or they can coat them and make them available for the phagocytosis. So all those things can be done by these B lymphocytes, and this is a part of humoral immunity. So if we get chance and we'll talk a class on the immunity, then we'll talk in detail about the functioning of B cell and T cell. T cells attach themselves to the bacteria or microorganisms and release the chemical directly into the T cells, into the bacteria or microorganism, and try to kill them directly by connecting cell to cell. And this is also called as the cellular immunity or cytotoxicity of the immunity. Then come to the variations in the count. Whenever there is increase in count is called lymphocytosis. Whenever there is decrease in count is called lymphopenia. Okay, increased physiology causes, all causes of leukocytosis are considered as the same causes for the lymphocytosis. Pathological causes, there is usually increase in chronic infections like tuberculosis or glandular fever or leprosy. This type of chronic infection, they shows a higher concentration of the lymphocytes. They also increase in viral infections like chickenpox, influenza, and other things. And then they also increase in autoimmune disorders like Graves' disease, are also called as thyrotoxicosis or Hashimoto's thyroiditis, or rheumatic heart diseases. In this condition also there is increase in lymphocyte count. Then viral infection like infectious mononucleosis, there also increase in lymphocytes count. Then come to the lymphopenia when this count is decreased below the 15,000 count, and it is shown in patient which has a hypoplastic bone marrow or exposure to the X-ray radiation or different type of radiations, or patient on a immunosuppressive therapy, specifically like steroid therapy or cytotoxic drugs. And also the lymphocyte count also decrease in AIDS, that is acquired immunodeficiency syndrome. Then come to the last cell, that is monocytes. Monocytes is one of the largest cell present in the blood, and diameter ranges from 12 to 20 micron, and that is one of the identification point. You can compare it; it's almost triple of the size of the RBCs. Then you come to the nucleus. Nucleus is usually present in central portion, like not like that of the lymphocytes, which is on the central peripheral or eccentric in nature. It is present in the central in nature, and it usually has an indentation, and that gives him the bean shape or kidney shape appearance because of that notch. Okay, and if you see cytoplasm is more of eosinophilic and stain with a very light play pink color, or sometimes a purple color will be there. And the granules does present, but these granules are not visible by the high power microscope. We need an electronic microscope to see. That's why they are also called as a azurophilic like granules. And these are granules usually stained with a very fine purple color granules. And it's contain loss of vacuoles in the cytoplasm. That one of the identification. No other cell contain vacuoles. Then come to the fate of the monocytes. It remains into the circulation once it releases up to 10 to 14 hours. Then it moves to the outside the blood vessels, that is in the tissue, and converted into macrophage, and that is called tissue macrophage. And this forms the reticuloendothelial system. and they can remain into tissue for days to years, and where they perform the various phagocytic functions. Now, function of the monocytes plays a very important role in defense mechanism, and it's from the first defense mechanism. So, moment anything enter in your body, the first cell which identify or attack on that foreign organism is a macrophage. So, macrophage will goes there and try to phagocytosis. Second line of defense is formed by the both neutrophil and monocytes. So monocyte and macrophage, they form a strong phagocytic combination and try to phagocytose the various bacteria. So monocytes also phagocytose, but it differs from the neutrophil that it can causes exocytosis. So if anything is undigested, it will can remove from the monocytes, and as compared to neutrophil, it is very strong phagocytic cells. Neutrophil can phagocyte 10 to 20. It can phagocyte as many as 100 of the bacteria. It also phagocytes the large cells, like it can phagocytose RBC also. So RBC, which infected with the malarial parasite and all those things, can also get phagocytosed by the monocytes. And, and the process of the phagocytosis is similar like that of the process of the neutrophil, so we'll not discuss it again. Monocytes along with the lymphocytes can also phagocytose the tumor cell whenever the tumor cell shows any antigenic reaction. It initiates the phagocytosis, and monocyte will cause the phagocytosis. Apart from this, monocytes also release various inflammatory mediators and participate in the inflammatory reactions, and also increases stimuluses. And one of the important functions of monocyte is antigen presenting. What normally T lymphocyte and B lymphocyte cannot recognize antigen directly, but they need to served by the antigen presenting cells. So what it does, monocyte will phagocytose the foreign microorganism, and whatever protein, the antigenic protein they contain, that protein will remain undigested, and they will present that protein on the surface of the monocytes along with the MHC molecule. And now T lymphocytes and B lymphocytes can recognize this as an antigen when they club with the MHC molecules. So helper T cell will recognize this antigen, and either they initiate a T cell or B cell, and they will initiate the immune response. So to initiate the acquired immune response, we need monocytes so that it can phagocytose. Then come to the variations in the count of the monocytosis. So monocytes, when the increased count is called monocytosis, when a decreased count is called monocytopenia. Increased count you can see in the chronic infections like tuberculosis, syphilis, or subacute bacterial endocarditis. Then infectious mononucleosis, name itself given because of higher concentration of the monocytes, and it is also called as a glandular fever. Then viral infection, protozoal infection, also there is increase in monocyte count. Decrease in monocyte count is usually very rarely, but it's shown when there is a bone marrow depression. So this is a picture, actual real pictures about these are the real pictures which you see under microscope, light microscope, uh, and they can identify. And these are drawings of the lymphocytes. So A is a neutrophil. You can easily identify their very fine granules, and three-lobe nucleus is there that you can see here. If you come to the eosinophil, you can see there is a pentacle-shaped nucleus and also bright red color granules. And if you compare the granules between eosinophil and neutrophil, so you can see the more turbidity in the eosinophil as compared to neutrophil because of coarse granules. Then come to the C cells. C cell is a basophil, and if you see the coarse, bright, dark blue color granules, you can see there, and this is almost so crowded that it closes completely look of the nucleus. So nucleus is almost covered by these coarse granules. So this is a basophil. If you come to D cells, you see this large nucleus with very scanty cytoplasm. They are a typical feature of lymphocyte, and that also shows ink spot appearance. So the D is not related to monocyte. D is coming here to lymphocytes, and this is a example of lymphocytes. Okay, then come to the monocyte. If you see compared to all of it is one of the largest cell. This is C shape of the nucleus and also cytoplasm, which is a light pale color. That is a identification of the monocytes. Then come to the another pathology condition is called leukemias. So when there is increased count of the WBC, we call it as a leukocytosis. But when the count goes beyond uh, more than lakhs, or when it goes into lakhs, then we call it as a leukemia. So whenever the WBC count goes above 50,000, then we consider it as a highly likely to be a leukemia. So leukemia ranges count from 1 to 3 lakhs per microliter, and cause is usually because of the increased bone marrow proliferation. So there is too much proliferation of the particular one lineage of the cell, and then that is called leukemia. Because of this higher proliferation of the particular cells, it will compromise the proliferation of the other cells. So compromise the proliferation of the RBC leads to anemia. Compromise the proliferation of the platelets leads to thrombocytopenia. Apart from this, it also involves the other organs, causing metastasis in other organs like spleen, liver, lymph nodes, meninges, bone, skin, brain, can affect those organs. And these leukemias in layman term is also called as a blood cancer. Depending upon what type of the cell is proliferated, leukemia can be divided into, if it is a myeloid lineage cell is proliferate, then we call it as a myeloid leukemia. If it is a lymphocytic cell proliferate, then we call it as a lymphoid leukemia. And depending upon the durations, if it is immediately changes occur, we call it as acute leukemia. And if it is take months to years, then we call it as a chronic leukemia. So in acute leukemia, the cells are very, very immature, and that's why the leukemias are called blastic leukemias. So there can be acute myeloblastic leukemia, acute lymphoblastic leukemia. They are very emergency condition and need to treat vigorously, but they can be cured. While chronic conditions are more of mature cell, you will see, and these are example chronic myeloid leukemia or chronic lymphoid leukemia. They are not emergency, but prognosis is very poor. Patient will ultimately die if not treated properly. इस्लाम तुम्हें जाना हो तो जाओ मेरा let me finish the topic. It's almost finished. Okay. So that's all for today. Any questions? Any doubt? Now, why this topic got delayed and all those things is because of your people nonsense.